Are the meeting platform hosts ready to begin?
Yes.
Mr. Chairman, are you ready to begin the hearing?
I am.
Please provide a 5-second countdown.
5, 4, 3, 2, 1. Well, good afternoon. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. The committee procedures for remote hearings remain the same. If you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. And without objection, members will be recognized in order of seniority for questioning witness today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the procedures for this hearing? Hearing none, we will proceed. I'll now recognize myself for an opening statement. Since March of 2020, VA leadership and Office of Emergency Management have had to continuously develop and redevelop the administration's capacity to respond to a global health disaster. In the earliest days of the COVID-19 pandemic, VHA began to see requests from states like New York and New Jersey to admit civilian patients to VA hospitals. VA had to rapidly find ways to simultaneously sustain its own capacity to provide care to veterans, prevent the spread of the virus among its workforce, and provide critical care to civilians, all without being able to fully estimate the scale of the danger of this new virus or the resources the system would need to fight it. The last 33 months have tested VHA and other federal health partners in ways they have never been tested before. With a majority elderly patient population, an aged infrastructure, an overworked and underpaid workforce, and an obligation to support the federal disaster response, VHA has delivered the performance of its lifetime. We have seen dozens of private healthcare systems effectively buckle and shrink under the strain of public health emergencies and natural disasters, workforce shortages, and infrastructure challenges. VHA has largely been able to avoid this, continuing to deliver the highest quality care to veterans. Now, that alone would have been a major accomplishment. But VHA also fulfilled its role as the backstop to the American healthcare system, providing assistance to nearly every state and territory and dozens of tribal nations. More than 6,000 VHA employees volunteered to deploy to assist civilian or tribal health systems since March of 2020. And because of its integrated nature, VHA's staff and supplies can move at a moment's notice to assist in a crisis across the country. But the strain of the pandemic has impacted all partners of the national disaster medical system. And the urgency of establishing interagency relationships and making structural change to how VA serves its humanitarian function has lessened as life gets closer to normal. Today, we will discuss 3 general themes. 1, what went right and what went wrong in that first year. Second, what longer-term problems, be they the structure of the 4th mission in VA or interagency partnerships across health systems, were put on the list of things we need to address when there's time. And is now that time? And third, what does VHA itself and VHA as a partner in the National Response Framework still have left to do to prepare and respond to the next public health emergency? Now, we're incredibly lucky to have with us 2 of the most knowledgeable authorities on managing a health system in a public health crisis. Dr. Richard Stone, former executive in charge of the Veterans Health Administration, and joining us remotely, Dr. Paul Kim, former executive director of VHA's Office of Emergency Management. On our second panel, we have several current public servants, many of whom were at VHA and IHS throughout the pandemic. Dr. Stephen Lieberman is VHA's Deputy Undersecretary for Health. Accompanied by Ms. Tammy Sarnecki, is VHA's Deputy Assistant Undersecretary for Health for Operations. Dr. Jane Kim is VHA's Executive Director for Preventative Medicine. And Ms. Carla Boyce is VA's Executive Director for the Office of Operations, Security, and Preparedness. And Dr. Rosalind So is the Director of the Indian Health Service. I'd like to note that both FEMA and HHS were invited to participate in today's hearing. Both declined. And given the role they played in the pandemic, we are extremely disappointed they didn't want to be part of today's discussion. I want to thank you, Ranking Member Bost, thank you for your accommodating our schedule today. It was last minute, and I realize it was inconvenient. And I want to thank all of our witnesses as well. And I want to recognize you for your opening remarks.
Thank you, Mr. Chairman. Well, good afternoon, everyone. You know, I look forward to hearing about how VA met the requirements for the fourth mission, a mission that can mean the difference between life and death when our nation is facing a public health emergency or natural disaster. As the largest healthcare system in the U.S., VA has a responsibility to not only care for veterans, but to also assist in the federal response efforts in emergencies and disasters. With the healthcare budget now exceeding $150 billion, Americans should expect a lot from the VA. VA is well established with the infrastructure and resources of geographic reach, deployment assets, a large workforce, and healthcare experience. All of that should be put them at the head of the table in coordinating national health and safety response. Unfortunately, that was not the case that happened during most of 2020. We started at the back of the table and had to struggle to play a prominent role in the nationwide response to the pandemic. At the beginning, the pandemic, VA sent a few representatives to HHS and FEMA. VA was involved in COVID response discussions. However, the full coordinated engagement with federal partners to manage the stress that COVID was putting on the nation's healthcare system was slow to evolve. VA also played a minimal role in the strategic national stockpile even after the shortage eased. The Biden administration tasked these agencies with a supply chain strategy for future pandemics over a year ago, and I'm still waiting to see what changes have been implemented. While if or when another viral outbreak may happen cannot be predicted, we do know with some certainty that VA's fourth mission capabilities will continue to be needed during the natural disaster. Now, I look forward to hearing more about the VA's coordinating operations in communities and devastated by the recent hurricanes and wildfires and around the country. Now, I welcome back Dr. Stone and Dr. Kim to our first panel, and I'm certain they will offer some valuable lessons learned and recommendations. Now, I am also, as the chairman said, I'm very disappointed that the VA, that FEMA and HHS chose not to send a representative to the second panel. So much of VA is able to respond depends on the coordination with them. Government silos do not serve anyone well, especially during an emergency or disaster. And with that, Mr. Chairman, I yield back.
Thank you, Ranking Member. I now call up and recognize our first witness panel. Dr. Richard Stone, former Executive Director in charge of Veterans Health Administration, U.S. Department of Veterans Affairs. Dr. Paul Kim, former Executive Director, Office of Emergency Management, Veterans Health Administration, U.S. Department of Veterans Affairs. I want to thank you all for being here, and I'll remind you to pause for 2 to 3 seconds before speaking and answering questions. Dr. Stone, what a pleasure it is to see you. You're no stranger to this committee, and I thank you for being here and welcome you back. You are recognized for 5 minutes to present your testimony.
Mr. Chairman, Ranking Member Bost, members of the committee, thank you for the opportunity to discuss the lessons that we learned as we led the Veterans Health Administration through the initial 18 months of the COVID-19 pandemic. We welcome the opportunity to support the ongoing bipartisan work of this committee as it considers how best to prepare for the next public health challenge. The opinions that we express today are our own. They do not necessarily reflect the opinions of our current or our former employers. We are here as private citizens who care deeply about our nation and its ability to handle crises. Let me begin by recognizing the extraordinary heroism of the employees of the VHA. Since the beginning of the pandemic, these outstanding men and women have been at the bedside of millions of veterans and have consistently volunteered to serve non-veterans severely infected with the COVID-19 virus. Their contributions have saved countless lives and demonstrated the remarkable skills VHA employees possess in the care of critically ill patients. Each one is a hero, and I appreciate you joining me in honoring them. I want to highlight 3 specific challenges that we as leaders faced in the pandemic, broadly defined as interagency coordination, supply chain risk, and the management of state veterans' homes. We recommend that this committee, and frankly all of government, consider changes in these areas as America prepares for future public health challenges. The National Security Act of 1947 established the current security structure that responds to threats against the American people. And this was followed in 2012 by the Biodefense Act that ordered the creation of a national biodefense plan and created actually a position on the NSC for biodefense expertise. Unfortunately, this change did not create the unified governance structure that is needed to facilitate an agile federal response to public health threats, resulting in substantial challenges in the delivery of federal health support to overwhelmed private sector health systems. We recommend that interagency governance of health emergencies be fundamentally re-examined in order to ensure there is a rapid, unified, and agile federal response to the provision of much-needed support to communities. Second, profound risk exists within America's medical supply chain. This partially occurred during the pandemic due to the significant amount of non-U.S. manufactured consumable and pharmaceutical products necessary to deliver healthcare support during this emergency. The lack of a robust domestic manufacturing base for these products constitutes, in our view, a fundamental national security risk and should be addressed. The overseas pharmaceutical manufacturing for essential medications to manage chronic and acute diseases fails to recognize that even America's closest allies will provide limited supply medications and materials first to their own citizens before meeting the demands of Americans. There is a model for mitigation of this risk. Congress created the DoD War Stopper program to ensure a domestic industrial base for essential materials used primarily in war, after recognizing material shortages following the 1991 Gulf War. Similar models of manufacturing and material stockage are possible for both PPE and pharmaceuticals that will protect Americans from future crises. Finally, we strongly recommend that this committee re-examine the authorities that VA possesses to correct operational and safety deficiencies identified in state-run veteran nursing facilities, where more than 25,000 veterans reside. VHA funds and inspects these facilities, and during the pandemic, these veterans were our most vulnerable. The lack of adequate staffing, infection control protocols, and available consumable supplies resulted in the deaths of many veterans in these state-owned and operated facilities. The VHA found itself supporting many of these locations because of our expertise in both elder care and infection control. The authorities that VHA possesses to make operational changes within these facilities needs to be re-examined. I will end with a note of thanks. When I left the VHA in July of 2021, I was encouraged to memorialize the leadership challenge that we faced responding to what is now recognized as the most lethal pandemic in more than 100 years. I wrote and released a book this past fall which provides substantial detail to the recommendations I have made in this statement, as well as attempting to tell some of the stories of the heroes of VHA. I specifically note in the book the bipartisan work of this committee and its leadership, and its professional staff that was so essential to our success. The significant funding of our emergency response contained in the 2020 CARES Act and the vision of the bipartisan leadership and the entire membership of this committee are a testament to good governance. And we thank you for being the partner that we needed to save every life that we possibly could. This concludes my opening statement. We welcome your questions.
Thank you, Dr. Stone, and without objection, your written testimony in full will be included in the hearing record. I now recognize myself for 5 minutes of questions. So, Dr. Stone, you're responsible for ensuring the success of the nation's largest integrated health system through the pandemic. You were also responsible for ensuring VHA was able to be the backstop for the civilian healthcare system, the Indian Health Service, and nursing homes throughout the country. And since leaving last year, you went on to get some sleep and write a book about your experience during the pandemic. And there's a lot we want to revisit with you. But I want to start with one of the more complicated topics, and that of interagency cooperation, which you mentioned in your testimony. You have discussed many of the times that you've had concerns about DoD's capacity to help civilians. These concerns started early in 2020 when VA was assisting DoD to quarantine cruise ship passengers. I don't know if you remember that. Later in the VA COVID response report from October 2020, you were quoted as saying, quote, DoD regards VA coupled with FEMA contract support as the primary healthcare response options for a national or regional public health emergency, end quote. Can you speak more to these concerns and what role you believe VA should have in national or regional public health emergencies?
The VHA is an extraordinary system with about 24,000 beds, 8,000 of which are acute care. The role of becoming a backstop to the American healthcare system, supporting 1 million beds nationally and 6,600 hospitals nationally as a backstop is a daunting task. It is well beyond what one single system can do, and therefore unifying the federal agencies in a unified response is absolutely necessary. The DoD is about 1/3 of size of a healthcare system of what VA possesses. Therefore, the two systems working cooperatively together is absolutely necessary. I do not in any way suggest in that statement that there should be preeminence of one over the other. And I believe that the ASPR, recently elevated to administration status under the current administration, should evolve as the coordinating agency that takes this type of work, coordinates all missions that comes in, and then works to assure there is uniform deployment, recognizing the primary missions that both of you recommended, you and the ranking member mentioned in your opening statements, that the primary mission can still be accomplished while becoming this backstop. Let me add to that the best example of this was the movement of the two major Navy hospital ships into both coasts and major cities in the nation. It took tremendous assets of DoD to accomplish that. As you look at the patient flow through those areas, the patient flow was very low, and it did very little to actually relieve the stress on the southern New York air catchment areas. After 3 weeks, they were released by the governor and the mayor. That entire movement took well over 1,000 uniformed personnel to accomplish. There could have been way better usage of those men and women to continue to fulfill the missions of DoD and VA than to accomplish that mission.
Well, thank you. I'm hoping a member will kind of tease that out some more, but I want to move on to my next question. Can you talk about, Dr. Stone, the authority to rapidly hire and provide bonuses to medical personnel during the pandemic? You were able to bring on 85,000 new employees, mostly nurses, in 10 months. How critical do you believe that was to VA success?
It was absolutely essential. Prior to the pandemic, it took us between 90 and 120 days to hire professional personnel, specifically licensed personnel that we needed to do multiple background checks as well as to verify their credentials. OPM was an extraordinary partner, and we actually were able to move to hiring in 3 to 5 days. We were substantially competing with private healthcare systems to hire, as we are today. And as you know, there's a shortage of 1 million nurses in America today. The competition for those nurses is extraordinary, and rapid hiring is necessary. I'm aware of a hiring fair that recently took place that was extremely successful by VHA personnel, and I'll defer to my current government colleagues and their panel to discuss that.
Well, thank you. I'm going to finish now and yield to Ranking Member Bost for his 5 minutes.
Thank you, Mr. Chairman. Dr. Stone, and we're going to keep going down about the same vein. And in hindsight, do you believe that the VA did everything it could have in support of COVID national health emergency, and should VA play a large role in future emergencies? And if so, what would that look like?
I think the VA has to continue to expand its capacity with mobile assets and remote capability to deliver care. Those mobile assets have primarily been used prior to COVID-19 in hurricanes and earthquakes and floods and fires, where after the fact we were able to come in and effect a support to a single region. In this case, we needed to support the entire nation simultaneously, and the only way we could do that is to move mobile assets. We did not have substantial ICU-related assets at the beginning of the pandemic. The CARES Act allowed us to expand that capability. Now, one of the things we found was that our DEMPS system, which is our deployable employment emergency response system, was made up of volunteers. Well, those volunteers coming from areas unaffected by an emergency were much different when the entire country was under pressure. And therefore, we did believe, or I did believe, that we should develop an additional classification of employee that spent 6 to 9 months of their work year maintaining their skill sets, and the other 6 to 9 months in readiness preparation for the next major national emergency. I think the expansion of that workforce would allow us to deploy a mobile 20-bed ICU to a hospital under pressure and deliver the labor force with it that was already competent in the utilization of those materials. And I think the development of both additional mobile assets, additional technology to transfer information using various advanced IT mobile systems, as well as an enhanced mobile labor force that could be involuntarily deployed, would be essential to our future success.
My next question is both for yourself and Dr. Kim. Based on your recent experiences, how would you categorize relationship and coordination among the National Response Framework federal agencies, namely the FEMA and HHS, who, as I stated in my opening remarks, declined to attend here today?
Let me defer to Dr. Kim, if possible, on the answer to this, because he's worked the interagency space for many decades.
Dr. Kim?
Thank you for the question. My relationship as the executive director of OEM was very good with both FEMA and HHS. My number was in their speed dial as well as their numbers. And it wasn't an issue of the contact and access. It was just the slow movement of the bureaucracy to get things in place. Contracting issues, the supply chain issues, transportation issues. So everyone was doing the best they could, but we were running into those challenges. One of the things that the CARES Act did for us, and Dr. Stone mentioned the hiring, I was able to hire people on my logistics staff because we couldn't get contracting for trucking and shipping companies. So we brought that ability in-house. We bought the assets to move things, and I hired the people to do the movements. So those were some of the challenges that I saw. But as far as my relationship with those other agencies and the working relationship, I didn't run into too many problems. It was all of the other things that we tried to coordinate and move forward.
Yeah, you know, it seems that, from my opinion, that the mechanism for requesting the mission support through FEMA is overly burdensome and does not capitalize on many of the capabilities that VA could bring to the national emergency. Would you say that's accurate, or could that process be streamlined in some potential way?
Paul, do you want to take that, or do you want me to take that?
Sure. I think it can be streamlined. I think that there's quite a bit of hand-wringing when the request goes out. I think that if and I don't know how we can streamline that process. I do know that, as I said in my initial statement, there were some other bureaucratic issues that we ran into with just the resources, the personnel, and the ability to move fast just was not there for a variety of reasons.
Yeah, thank you both for those answers, and my time has expired, so I yield back.
Thank you, Ranking Member Boss, for that line of question. I think we need to get more to the heart of that. I now recognize Chairwoman Brownlee for 5 minutes.
Thank you, Mr. Chairman, and thank you, Dr. Stone and Dr. Kim, for being here today, but particularly thank you for your leadership during a very, very challenging time within the VA and within our country. So thank you for that. I wanted to talk a little bit about the state of veteran homes, and Dr. Stone, you mentioned that as one area of concern, and it sounds like, you know, state veteran homes have a standard that they are supposed to meet, and the VA is sort of responsible for overseeing that they're meeting that standard, but yet they have no mechanism really to do any kind of enforcement. And there was a GAO study that found that between 2019 and 2021, there was a significant increase in both the number and severity of deficiencies cited by the VA at state veterans' homes. So you talked about needing additional authorities. Could you detail what you mean by additional authorities?
First and foremost, our responsibility when reviewing these homes would be to protect the safety of veterans and their spouses, often, that are confined to those facilities. There is no ability under current law, specifically VHA is precluded from assuming operational control even when safety violations are found. All we can do is recommend to the state what needs to be corrected and then come back and reinspect. Now, you can stop admitting new veterans, but that doesn't protect the veterans that are housed within those facilities. It is our recommendation, I'm specifically speaking for Dr. Kim and myself, our recommendation that additional authorities are given to VHA to assume operational control during emergent situations when there is not time to protect patient safety. The model of care in most of those nursing homes is very similar to what we found in civilian or commercial nursing homes, which are mainly staffed by nursing assistants, not professional nurses. The difference in a VHA nursing home is twofold. Number one, the presence of the professional nurse, and the professional nurse's ability to be at the bedside with robust understanding of infection control and disease process control. Number two, the co-location of VA extended care facilities with acute care facilities so that we could bring in infection control experts and elder care experts at much higher levels than we found in virtually any commercial nursing home in the nation. This different model resulted in dramatically lower death rates in VHA-owned facilities versus state-owned facilities. That ability to assume operational control, Congresswoman Brownlee, is the key and the centerpiece. Now, I do not in any way presume that VHA or recommend that VHA should own these facilities. There is a proud relationship between states and their veterans, and that should continue and should be encouraged. But the ability to protect safety must be taken first.
If you had had that authority during the pandemic, do you think you would have saved lives?
I am hesitant to say that we could have saved lives depending on when we got in. But I think that if we had corrected deficiencies at an earlier state, we could have protected veterans from the ultimate outcome. And so I would have to agree with your statement.
Going back to this, I only have a little bit of time, but this interagency coordination, I'm just curious whether, I'm not sure I'm using the proper description, but have you done a mock trial with the other agencies, or did you ever do sort of a mock trial with the other agencies preparing for that coordination in anticipation of a national disaster?
So there's two authorities under which this operates. The first is ESF 8, Emergency Support Function 8, which is the medical response to the federal government during an emergency. Underneath ESF 8 is the NDMS system, the National Defense Medical Response System. That is a system that grew up at a different time in American medicine. And the NDMS system needs a fundamental review of how functional it still is. There is well over 6,000 commercial participants in the NDMS system. I think there is substantial coordination going on today in the DoD system, and I know in the VA system, to try to understand how much of a partner can commercial systems actually be in the NDMS as it exists today. And I would strongly recommend a review of NDMS as we think about a way forward in the national response.
Thank you for that, and Mr. Chairman, I yield back.
Thank you, Ms. Brownlee. I thought your questions were really getting to the point of what we needed to examine here, so thank you. I want to now recognize Mr. Lamb for 5 minutes.
Thank you, Mr. Chairman, and thank you, Dr. Stone, for coming back to us. You've spent a lot of your life in government service, particularly providing health care for active duty soldiers and veterans. But you've had some experience in the private sector as well, I know, and some chances to work with private healthcare agencies. I guess I'm just curious, has the VA's experience during the pandemic, has it made you rethink at all the model of private civilian healthcare that we have in this country? And the reason I ask that is because from my perspective, it seemed like every time we talked to you or Secretary Wilkie or I talked to the leadership at the VA hospitals in Pittsburgh, they were very attuned to the problems of the pandemic and dealing with them, but they were not experiencing, from what I could see, the same levels of stress and dread that their civilian private sector counterparts were. I think in part because the economics are so different. You know, the VA just is not fee for service. You knew that we were going to keep appropriating funds. Obviously, the patient flow is totally different, but it just seemed like the VA had some spare capacity to absorb a crisis like this and even go out beyond its own borders and help others, as we've talked about here today, whereas so much of the civilian healthcare system is kind of barely enough, just in time, paying for every little service, so that when you lost access to hip transplants and knee replacements and that sort of thing, it was threatening the economics of even very successful hospitals and systems. So it's just a very open-ended question of whether what you saw during that time has led you to rethink anything about the way we do healthcare more generally in this country.
Congressman, a really well-run healthcare system runs at 85 to 90% capacity. with very little ability to expand delivery beyond the existing licensed beds. We were able to add 8,000 acute care beds and then to put those into service very quickly. Now, that happened for a couple of reasons. Number one, we had a lot of facility space available. We have an ancient system inside the VHA, but those big old buildings were able to accommodate expansion very quickly. We were able to hire quickly and incentivize hiring, and we hired 85,000 people. And we had the resources, because of your work, we had the resources to do that. None of those things occurred in the commercial space. In the commercial space, you have an unprecedented financial pressure, even today, 2 years later, on those systems. And the high-profile systems that have struggled with billion-dollar losses does make me question the long-term viability of the model. The model of just-in-time, if we are going to view the VHA, which I strongly recommend as the backstop to the American healthcare system, it has to have the redundancy built into it and the resources to do rapid expansion. Now, we started the pandemic just like a commercial system with about an 85% occupancy rate of our beds. We had very little capacity, but we recognized very quickly that our critical care expertise, which is extraordinary, had to be extended to the commercial marketplace, and that's why we moved forward in that manner. It is not a surprise to you that I view the VHA system as the finest healthcare system in the nation and a model for the rest of the nation. Now, as I say that, that doesn't mean we don't have challenges, but it has made me rethink the capacity of this system to absorb and what we must protect. It's one of the reasons that I believe we cannot retreat back to our corners after this pandemic gets over with. If we do that and fail to learn the lessons, fail to force the dialogue that can occur from this level between the agencies, shame on us if we get to that point. We must continue to force these agencies to talk to each other and to think about what the future should look like.
No, I agree with you completely, and I commend you for the work that you did during that very hard and trying time. And I just think it seems like even if we funded and executed the expansion of this part of VA's mission perfectly, we would still have so far to go. I mean, 8,000 beds is great, but it's in the scope of a national emergency. There is just so much more that we need to do. So I appreciate your thoughts, and again, for coming in. Mr. Chairman, I yield back.
Thank you, Mr. Lamb. That was truly a fascinating question and a fascinating response. A lot of food for thought here. Mr. Mervan, you're recognized for 5 minutes.
Thank you, Chairman Takano and Ranking Member Bost, for putting this committee. Dr. Stone, in your testimony, you discuss an idea for strengthening this country's pharmaceutical supply chain resiliency by modeling after the DoD's War Stopper program. The DoD's War Reserve Management or War Stopper program mandated the formation of a program to create a domestic industrial base for essential materials used primarily in wartime. Your idea is the same base should be established for essential pharmaceuticals, nearly all of which are manufactured abroad. If you could tell me a little bit more about the vulnerabilities you think we face and how such a program would work.
Top 110 drugs used in this country are manufactured other places besides the United States. You have two choices. You can work to bring pharmaceutical manufacturing back into the United States to assure its availability for Americans, or you can develop a warm base, which the War Stopper program does for things like nerve agents that aren't used except in wartime. And by managing that base actively and funding a amount of manufacturing necessary to provide the surge capacity of the pharmaceutical industry in this country, you could accomplish the same sort of thing. So I think there's two tracks that could be taken in this. To move manufacturing completely into the United States would be a very difficult process, partially because the APIs, the root chemicals that go into pharmaceuticals, are not manufactured or mined in this country either. And so this is a very complex response. I do find, having been in the military during the 1991 war, I do find that Congress's response to the shortages of the Gulf War provided an extraordinary strengthening of our readiness for reserve materials, and I think it is a model that should be examined.
You also suggest a public health crisis simulation exercise regularly conducted by the ASPR to ensure coordinated patient care between federal, tribal, and commercial delivery networks. My understanding is that as part of the National Disaster Medical System, VA already participates in such simulations. Are you suggesting they don't or they do not enough?
It's not enough. It's not enough, sir. Let me say a couple of things about that. In southern New York, when New York hospitals were overwhelmed, we were dependent upon cell phone communication between people that knew each other because they lived in the community together. We had not practiced the system to the point that when commercial systems were overwhelmed, that we could smoothly inherit missions and move through the bureaucracy. Dr. Kim talked about the slow-moving bureaucracy. I want you to think about a healthcare leader or a chief of staff in Manhattan overwhelmed with patients, having to call the governor's office, move through the governor's approval, have that sent to the president moving it through this system for approval while patients accumulate in the hallways of their facilities. It's just too slow a system. And just the ability to communicate with each other needs to be exercised in a much more robust manner than we do today.
As a point of clarity for me, the tabletop exercises, who's responsible for the exercise and the execution of them?
I think ESF 8 falls under the HHS and the ASPR's office.
And the VA falls underneath that?
VA would come into that portion of response as a contributor of assets to that, yes.
Also, in your book, you suggest Congress should mandate the expansion of the ESF 8 function to enhance care coordination. Can you tell us a little bit what that function doesn't do now that an expansion would accomplish?
ESF 8 acknowledges in its opening that delivery of health care in America is done by commercial health care systems and therefore does not comment on that. It spends almost its entirety on the emergency transportation. It can supply amazing numbers of ambulances to move patients, but depends on the delivery of health care in the commercial space. Also spends a lot of time talking about supply chain as well as mortuary affairs. It's my view that ESF 8 needs to be re-examined in light of this once-in-a-100-year pandemic. And you need to take a look at how you force coordination. Now, is it part of that NDMS system? Is it part of really an evolving next generation of NDMS? That is something that really needs to be worked through. But at this point, this system is fairly fragmented.
Thank you. With that, I yield back.
Well, thank you, Mr. Mervan. These are incredible questions. This is an incredible hearing. Mr. Allred, go ahead. 5 minutes.
Sure. Well, thank you, Mr. Chairman, and I want to thank Dr. Stone, Dr. Kim, for your testimony. Dr. Stone, it's good to see you again, to have you back. You and I have had more interaction, I think, around getting the Garland VA opened, and I really want to thank you for that. I think you've done a real service to your nation with your testimony here today and with the look back that you provided. And, I want to echo your testimony discussing the hard work and heroism and sacrifice of VHA employees. I saw it myself in the Dallas area, how they responded. And, I think as much as your recommendations point out things we need to change, we also, should thank the folks who did that and who stepped up during that crisis. And as you remember, I'm sure at the beginning of the pandemic, VA opened the Garland VA Medical Center, which we worked on in terms of negotiating for some time in my district. And while the acquisition of the facility predated the pandemic by a few weeks, it put VA in a position to open a new 140-bed facility at the height of the pandemic and allowed VA to immediately begin caring for COVID-19 patient veterans at the facility, also creating a backstop for our civilian system. And I wanted to ask about the VA's infrastructure needs and how they impacted our fourth mission during the pandemic, our ability to provide assistance to veterans in their communities, and also how DoD facilities come into that conversation, because certainly we got, I think, a little bit lucky in Dallas, in the Garland VA, just weeks ahead of really the height of the pandemic, and VHA staff worked extremely hard to turn that facility around quickly. Otherwise, we would not have had that excess backstop available that we did in our area.
Congressman, let me say a couple of things first. Thank you. Thank you for your comments, but most importantly, thank you for the vision you showed in bringing that Garland facility to us. As you all know, the VA Medical Center in Dallas is landlocked. It has no ability to expand and is frankly too busy to take down pieces of the facility and figure out a way to expand it or to modernize it. The presence of the Garland facility, which really came to be mostly because of your hard work and your diligence in bringing that together, so thank you on behalf of all veterans. It was a perfect example of what's wrong with our infrastructure. We're landlocked in many areas, we've got old facilities, and we need the flexibility of adding additional space. Now that hospital, even though it's a 1960s era hospital, gave us the perfect ability in an area of Dallas that we were growing rapidly in, and gave us well over 100 beds that we could expand into during the pandemic. It made that entire Dallas market, when it was challenged by COVID, we were able to respond without the need to move additional mobile assets into it. And all I can do is say thank you. I think it's a perfect example of a public-private partnership. Saved the United States government and the American taxpayer extraordinary amounts of capital. My view was $500 million in capital that was saved, and it's an asset now that's in extraordinary use. So thank you for your support of that.
Well, thank you. We couldn't have done it without you and your office. Y'all had to figure out how to put some square pegs in round holes. I only have a little bit of time left, but I was interested to see that VA was left out of, at the beginning of the pandemic, VA was left out of most interagency work groups. It was not a part of the COVID-19 task force. Now, some of that changed. DOD was, though, I think, a part of some of those early interagency groups. In your recommendations, is that addressed in your recommendations around how to use the former ASPR coordinating administration, or would that still be an issue, or do you think we've learned that lesson now that VA will be at the table?
I think it remains to be seen as the development of the administration around the ASPR occurs. It's my view that VHA, DOD, Indian Health Service, Public Health Service, NIH ought to all be at the table as providers of the federal response to needs. Remember, we started the pandemic with over 120 requests for federal support. Yeah. Just adjudicating that, of who were you going to go to first and how, was complicated by the fact that there was no structure. Now, out of frustration of this interagency lack of coordination, the President stood up an ad hoc committee under the control of the Vice President. It was a valiant attempt to get structure, but that also did not include healthcare operations or healthcare delivery. It included some extraordinary people in public health, and you've heard from them throughout the last 2 years. But what you have not heard from until today is the role of healthcare delivery operations. And that's the voice that was missing, and a fundamental weakness that in whatever response this nation takes to prepare better for the next public health emergency, healthcare operations in a coordinated manner of the federal response should be at the table, and every piece should be at the table.
Well, Mr. Chairman, my time has obviously expired, but I think that, as I said, Dr. Stone, y'all have provided a real service to the country during the pandemic, but then these recommendations are going to help us save lives with any future crises. So thank you.
Thank you, Congressman Elwood. I'm going to go for a second round of questioning. So, Dr. Stone, I'll recognize myself. You and I have had conversations many times during the height of the pandemic about the need to reform VA's fourth mission. You had suggested three main reforms. One, a dedicated program office with dedicated staff at VA. Two, a partnership with the Public Health Service to have access to uniformed medical staff who could deploy to areas that VA volunteer force may not want to go. And three, to rearrange the structure of the National Disaster Medical System to make VHA the primary healthcare responder rather than DoD. Obviously, this is a partnership you know well. I want to give you some time to talk more about these ideas, clarify them. I know that some other members have asked you aspects of it, but I want you to elaborate on something on these ideas to the extent that you haven't been able to so far.
So with your permission, I'd like Dr. Kim to respond to the PMO portion of this. Dr. Kim?
Thank you for the question. One of the areas that Dr. Stone briefly spoke about is VA's ability to be mobile. And in late March of 2020, we became aware of a mobile capability that was very unique. It was a mobile ICU unit. And by April of that same year, we had this unit in operation supporting the pandemic. And this unit has been a game changer. When I briefed Dr. Stone about this unit, we both agreed that this would help us and change the trajectory of the pandemic for us because of the lack of ICU beds. We have since, because of the success of that unit, VHA has purchased 3 other like units. We have that unit, the initial unit was deployed 6 times during the pandemic and was able to support several medical centers and in particular hotspots across the country. And it's currently now deployed to a medical center that's dealing with infrastructure and construction issues. So I support what Dr. Stone was referring to as VAs being able to be mobile. One of the other areas that he spoke of as far as VA being at the table or VHA being at the table, the exercises that were briefly spoke about, they happen at the action officer and field level, but we really need to be focusing on the senior leadership, the ASPR, the Undersecretary of Health, and the other high-ranking officials. They need to be at the table during these exercises to coordinate and to see how these things operate and to see how what are the things that are preventing us from moving quickly and getting around those bureaucratic obstacles. So those are a couple of areas that I think moving forward as far as VHA or VA being at the table really need to happen as we move forward. The next major emergency is just around the corner and it's unfortunately on its way. So we need to be working on these pretty quickly.
So let me add a couple of things to Dr. Kim's comments. I think a closer partnership with the public health services would go a long way to helping this labor force. As I went through a 2.5-decade career in DOD, right next to me was always public health service officers, and they were inside DOD. When I came to VA, that is not true. There is some public health service presence, but it's very minimal. It was my impression that this was the first time in a response that I didn't have the ability to involuntarily move employees where I needed to. When I was in combat, I could say, here's where you're going, and you were going there. In the VA, I had no ability to involuntarily move people. So one of the things we examined early in the pandemic is what should the relationship to the public health service be? Could we actually educate new physicians and nurses through the Uniformed Services University, cover their tuition, get them to full licensure, and then could we have them pay back that debt through years of service to VA, just like is done inside the DOD through the training program. That program has been examined and taken a look at. I think everybody's supportive. Whether it's moved forward or not, since I left the system, I would defer to my government colleagues, my current government colleagues, of what the status of that is. But I think it still bears very valid approach. I've talked a fair amount about NDMS, and I do think that the evolution of NDMS is dependent upon a relook at Emergency Support Function 8. And as Dr. Kim has referred to, whatever we're going to do with NDMS in the future, we need to recognize that already the VA is the primary participant as the coordinating agent in the vast number of those SCCs that are out. About 15 are still currently covered by DOD. I know that DOD is actively working to take a look at what their relationship is. And this is why the members of HHS as well as FEMA need to comment on anything that I'm saying today.
Thank you, Dr. Stone. Ms. Brownlee, do you have any more questions? I'm sorry, Ms. Brownlee, I should have gone to Mr. Bost, Ranking Member Bost. My mistake.
No problem. So, Dr. Stone, Dr. Kim, do you believe that VA's physical infrastructure is resilient enough to withstand what appears to be increasingly severe weather emergencies? What are the system's greatest vulnerabilities now that you've been away from it for a while?
No, I think this system needs to be recapitalized. This is a system, some of these were built on places when we still believed in a sanctuary model of 350 acres of property with a hospital in the center of it. This is just not the model of healthcare delivery today. We need to recognize the continuing evolution of home care. We have over 200,000 veterans in home care today. Those are veterans that would have been institutionalized in facilities previously. And we need, therefore, a recapitalization of this system. We also need to recognize that veterans are no longer in places that we need to re-examine. And I'm well aware of the evolution of the Air Commission, as well as the work done under the Mission Act, in which we took a look at what the requirements were of the system. But I think one of the toughest things you're going to have to tackle is how to recapitalize this system and how to recognize that we need brick and mortar facilities where veterans are, not hours away from them.
I appreciate that answer. I just hope that maybe the Senate heard that answer so that they'll get to work and go ahead and appoint the Air Commission. But that's just me saying that. So, thank you. That's all the questions I have. Thank you, Mr. Chairman. I yield back.
Thank you, Ranking Member Bost. Now, Chairwoman Brownlee, sorry, go ahead.
Thank you, Mr. Chairman. I wanted to begin where I left off, Dr. Stone, when you were talking about, the interagency coordination and so forth and how it needs to be improved, and you went into some detail about that, which I appreciate. I wanted to get to this place of, of asking the question, is there any kind of sort of mock trial, and maybe that's not the exact way to describe it, but having exercises to practice in advance of a national disaster? Is there, are there any exercises like that you were aware of that took place or does take place to make sure that interagency coordination, everybody understands what their roles and responsibilities are?
In my 3 years at the VHA, we did not conduct any of those interagency exercises at the level that Dr. Kim referred to. Now, at the action officer level, there was coordination. But when you got to the highest levels of the organization, we did not conduct that level of interagency coordination. And therefore, I think there was substantial weaknesses. I think that was a real weakness of how we approached this pandemic. And it took us a long time. In fact, Dr. Lieberman led a team that went into HHS on a daily basis and FEMA and helped work with some senior SESs to make sure that we were communicating effectively. Many of you have referred to how long it took us to really get to the table. And part of that was the work of Secretary Wilkie, who went and sat with the secretaries of HHS and really worked to make sure that they fully understood the capability of the VHA and how much it brought to the table and how many assets were available to it, as well as the robust and growing capacity that we had as the pandemic occurred. I would follow on the chairman's remarks that as we did this, we also grew our capacity substantially when the vaccines were introduced. And when the vaccines were introduced, we had substantial capacity that we could actually reach out into civilian community to support them. I personally was up in the Bronx giving vaccines in a underserved and disadvantaged community. And that was done by each of us that sits the current government. Representatives that are here today, we're all out giving vaccine. And that's the level of change that Congresswoman Brownlee that is necessary, that really exercises these sort of challenges at the appropriate levels and make sure that the challenges get visibility right up through the undersecretary and secretary level.
Thanks. And just very, very quickly, every opportunity I have, I'm always trying to push my Elizabeth Dole and Community-Based Services for Veterans Act, which in essence basically takes all of the in-home community services that the VA offers now and expand those programs so that disabled veterans and aging veterans have the choice of staying at home. So if we had more veterans at home and not in institutionalized care, which still the ratio is still, I think currently now it's about 65% in institutional care of our older and disabled veterans. Do you think there would have the outcomes would have been better for our elderly during the pandemic if they had been at home?
Yes. Yes. Remember that there's 8,000 veterans in VHA nursing homes, 25,000 in state homes. Then there is also the purchase of commercial home space. Those veterans in their homes is better. I don't think it takes very long for you and I to figure out that at the point that you need to make a decision on where I go, I want to stay at home as long as I can be at home. And all of us would answer the same way.
As a doctor, you believe that the health outcomes are better for veterans if they are at home versus institutionalized care?
I think they are better. With some exceptions. There comes a point when families can no longer care for people with cognitive decline, when an elderly spouse and family members just can't do it anymore. And there is an appropriate role for institutionalization. But I think institutionalization should recognize the fact that there is substantial ability to deliver enhanced care at home, and the VHA has done an extraordinary job under the programs that you've mandated that has allowed the continued growth in the number of veterans receiving those services at home and therefore having prolonged stays at home with their family members.
Thank you, Dr. Stone. My time is over. I appreciate you being here. And Mr. Chairman, I yield back.
Thank you, Chairman Brownlee, and I think it's totally appropriate that you keep promoting your bill. That's a very important policy that we need to continue to push. Yes. So, Dr. Stone, thank you so much for sharing your insights with us. No, yes. So I do want to excuse you. I want to continue reading your book and to internalize everything that you have, the wisdom you've had to share. And we thank you for coming today and braving traffic and starting a few hours late. But thank you so much. Thank you. I now would like to move to our second panel. And I got to get to the page where we have the second panel. So panel, yeah. So I now call up and recognize our second panel. And with us is Dr. Steve Lieberman, Deputy Undersecretary for Health, the Veterans Health Administration, U.S. Department of Veterans Affairs. Welcome, Dr. Lieberman. Accompanied by Ms. Tammy Zarnecki, Deputy Assistant Undersecretary for Health for Operations, and Dr. Jane Kim, Executive Director for Preventative Medicine, and Ms. Carla Boyce, Executive Director, Operations, Security, and Preparedness, and Ms. Rosalind So, Director of the Indian Health Service, U.S. Department of Health and Human Services. So I want to thank you all for being here. I know that you made it across town in rush hour traffic, and I thank you for that. I'll remind you all to pause for 2 to 3 seconds before speaking and answering questions. Now we'll begin. Thank you, Cassie. So, Dr. Lieberman, I'm going to recognize you for 5 minutes to present your testimony. Thank you. And by the way, Dr. Lieberman requested 7 minutes, and I'm going to, 7 minutes if you, I know you have a lot of substance to convey, and I recognize you for 7 minutes. Thank you.
Good day, Chairman Takano, Ranking Member Bost, and members of the committee. I am pleased to be here today to discuss VA's role in response to the COVID-19 pandemic. I am accompanied today by Ms. Tammy Zarnecki, Deputy Assistant Undersecretary for Health for Operations, Dr. Jane Kim, Executive Director of Preventive Medicine, and Ms. Carla Boyce, Executive Director, Emergency Management and Resilience. I first want to acknowledge our exceptional workforce. I am immensely grateful to have served with them these past 2.5 years and who came to work every day under the most trying of circumstances to keep our nation's veterans and their communities safe. Remarkable employees worked long hours with extra shifts in full personal protective equipment, often under conditions of fear and uncertainty, sometimes while also dealing with their own grief. To my VA colleagues, thank you for all that you have done and continue to do during this pandemic. I now want to take a moment to remember the 23,390 veterans and 277 VA employees we lost to this disease. Each one of these losses is a tragedy for their families, veteran community, and VA staff. I want to express my gratitude to Congress for providing $19.6 billion through the CARES Act and $17.1 billion from the American Rescue Plan. This funding enabled us to optimize care by enhancing items including staffing supplies, equipment, and renovations. CARES Act funding also provided essential to addressing the economic and health care needs of veterans experiencing homelessness or who were at risk. The resources and hiring flexibility Congress provided enabled VHA to hire over 136 new staff during the pandemic, including a record number of new hires during the last fiscal year to augment our delivery of care. One nurse in Boston who retired after 37 years was compelled to rejoin VA to help care for veterans again. Our growth in staff was critical to fulfill our fourth mission as the backdrop to America's healthcare system. While we had prior experience deploying personnel, our role during the pandemic grew to an unprecedented scale and scope. Thousands of employees voluntarily traveled to other VA medical centers, community hospitals, state veterans homes, and private nursing homes, providing care, consultative advice, education, training, and vaccinations. We participated in 196 missions in a total of 48 states, as well as territories, as well as 19 missions supporting tribal nations, including admitting American Indians to VA facilities, supporting those experiencing homelessness, and sending staff to support Indian health care systems. Another mission example was sending 15 six-person clinical teams from VA facilities in Florida to provide consultation, training, and care in over 80 long-term care facilities across the state of Florida, helping over 8,800 patients. In Idaho, VA laboratories completed over 18,000 tests to the state. We also admitted almost 700 non-veteran patients to VA facilities to help decompress outside hospitals overwhelmed by COVID-19. We expanded our telehealth capacity quickly and delivered over 22 million video visits to veterans over the past 3 years, an increase of 3,000% since before the pandemic. We also fully vaccinated more than 4.2 million veterans, with over 2.2 million veterans receiving additional vaccine doses. Our staff understood the importance of providing these life-saving vaccines, like the Tampa VA nurses, who kept administering vaccines in the parking lot after a fire alarm had cleared the building. We've also done an amazing amount of research on COVID-19. Starting in January 1, 2021, over the ensuing next 19 months, we published over 1,300 COVID-related research publications. We also collaborated with DoD on the natural history of those having COVID. For 2 years, we've worked with NIH on COVID-19 therapeutic interventions and vaccine trials, also partnered with BARDA to obtain insight onto COVID treatments, and 39 VA facilities joined one or more of 7 large-scale COVID-19 therapeutic and vaccine trials. VA was among the first in the nation to establish long COVID programs. In August of 2022, we publicly released our whole system approach to long COVID, which identifies common symptoms and conditions and provides management recommendations for this terrible syndrome. During the pandemic, VA's Office of Information Technology supported Veterans Cares using ARP and CARES funding for additional medical devices, computers, tablets, mobile devices, software, and technical services. For example, San Diego VA adapted video technology and intensive care unit to allow patients to better communicate with their care teams. Protecting our workforce and supporting their well-being has remained of the utmost importance to us. The pandemic aggravated the long-term healthcare industry challenge of burnout and exhaustion. In response, we initiated a system-wide endeavor called Reboot to address burnout and promote well-being among our employees. In conclusion, VA has committed to providing high-quality benefits and care to veterans during these unprecedented times. VA's success is directly attributed to our employees' dedication and commitment to veterans. The extraordinary efforts of our frontline staff continue to inspire me. This includes 2 Iowa City VA social workers who worked to ensure a veteran in their care could have a final conversation virtually with his wife. Thank you, Mr. Chairman, and all of the members of this committee for your continued support that has been essential to serving veterans during these challenging times. My colleagues and I are prepared to address any questions you may have.
Thank you so much, Dr. Lieberman. I now would like to call on Ms. So. You're recognized for 5 minutes to present your testimony.
Thank you. Good evening, Chairman Takano and Ranking Member Baust and the members of the committee. Thank you for the opportunity to testify on the Indian Health Service's continued efforts to respond to and mitigate the impact of COVID-19 in our Native communities by collaborating with our urban programs and tribal partners throughout Indian country. We also want to elaborate on the very productive and responsive efforts to the COVID-19 pandemic with the Veterans Affairs. I know that we are late in time, so I'm going to get right to it. Since the start of the pandemic, IHS has worked closely with our tribal partners and our urban organizations and state, public, and other federal entities, including the Veterans Administration, to combat the COVID-19 pandemic. Our number one priority has been and continues to be the safe care to our patients in the Indian Health Service and all through Indian country. The Indian Health Service continues to play a key role as part of the national effort and response to prevent, detect, treat, and recover from the COVID-19 pandemic. We know also that there were several examples that Indian Health Service wants to share in our partnership with the Veterans VA. Throughout my career, I have worked very closely with the Veterans Administration out in the Northwest and throughout other parts of my role and throughout the nation. In the Phoenix area, though, we leveraged the IHS VA interagency agreement to augment IHS staffing at the White River Indian Hospital and the Hopi Health Care Center in Arizona through multiple VA staff deployments. The same interagency agreement was deployed also in the Navajo area, and by the way, I was in the Navajo region at the height of the pandemic out in Indian country. And during the COVID-19 pandemic, we also worked very closely with the Veterans Administration. During this period, and particularly in the Navajo area, the VA deployed 14 emergency department and med-surg registered nurse to the Gallup Indian Medical Center. The VA also supported the available nurses during the time when we were not able to secure the nurses that we desperately needed, and also the rates of compensating nurses through contracts was extremely high. So the VA did work with us to continue to allow us to have those nurses until we were able to stabilize our staffing situation in the Navajo area. During this time as well, the Navajo and the Phoenix area entered into several interagency agreements with the Veterans Administration, including the Albuquerque VA, Grand Junction, Colorado, Salt Lake City, Utah, Phoenix, Arizona, and Tucson. And these agreements provided us the opportunity to place non-VA patients during this period at VA facilities. We also worked, at least from the Navajo area, worked very closely with the VA Medical Center and worked very closely with the staff there that helped us make sure that we were able to cover the needs at the Gallup Indian Medical Center. Additional examples include the VA loaned the Parker Indian Hospital Center 2 transport ventilators for more than 6 months. The Phoenix Area Indian Medical Center and the Phoenix VA pharmacy programs also collaborated on a number of items throughout the pandemic, including the development of new processes for curbside pharmacy services. There was also in that same effort a contingency plan for chemotherapy services to continue to go on between the two organizations. In September of 2021, the Indian Health Service, Oklahoma City Indian Health Service, had a patient that needed to be placed in a facility, and Through that collaboration with the Oklahoma area IHS and the Oklahoma VA, we were able to place that patient for services at the Oklahoma VA instead of moving them out further from their home and from their family. The patient was transferred to the facility, and the services that were desperately needed were provided. We look forward to continued collaboration and work with our tribal partners as well as the VA. As we work towards recovery, we continue to work closely with the stakeholders and understand the importance of working with partners during these difficult times. Thank you again for the opportunity to speak with you today, and I'm ready for questions as well. Thank you.
Thank you so much, Ms. So. I will now recognize myself for 5 minutes for questions. Excuse me. This sound is so. So, Dr. Liebman, I want to begin with you. We know that you were at daily coordination meetings at the FEMA Coordination Center for most of the pandemic. Tell us about your experience and the interagency fragmentation in those early days.
So I was on the first ever VA member on the ESF-8 organization for the first year of the pandemic. I joined it with Dr. Stone's suggestion when we were not getting recognized as what VA truly had to offer with the fourth mission. I joined it in late springtime of 2020. And so I served on that for about a year, and then Ms. Zarnecki served on it for a second year. And it was really vital that VA was at the table. And in the first few days, there was very welcoming, but as they were looking at assignments and what was needed to support around the country, there was going to their usual other federal agencies. And so in the first few days, I reminded them that VA was here and we had a lot to offer. And it just took a few days till they recognized that we were a major force to help support the country at this challenging time. And very quickly, we were there, and it was always on every meeting, what can VA do? Or I would volunteer what VA could do. And we met 7 days a week for a long time in those early challenging days of the pandemic. But it was a very collaborative work.
It took some time for people to figure out what the capacity of the VA was. You were primarily responsible for helping local leaders make requests through their governor's offices for help from their local VA medical centers. That's the process that has to go through. A state has to request this. This process outlined by the Stafford Act is time-intensive and in some ways delayed VA from providing care. And as I understand it from Dr. Stone's book, the VA leadership made the decision to provide humanitarian care if there was a safe assumption a mission assignment would eventually be granted. My question to you is, what does VA need from Congress to ensure that you are able to offer humanitarian assistance more quickly in cases where waiting for paperwork to clear could mean the difference between life and death?
So the way it is set up now is that the states have to concur as a part of it that they want us to come in. So sometimes we would be asked by a local municipality to help out, but it's still the process is it has to be approved by the state because it's a state request. So there certainly sometimes was a slowdown with that. Otherwise, we were certainly experienced in the process from our prior performing the much smaller number of missions that we had participated in. So the process would work, but it was really when the states was where the slowdown was sometimes. And certainly we wanted to do everything we could from the humanitarian side. Certainly we can come talk to you, sir, and other members of Congress to think if there's a better way to do this.
As I recall, Dr. Lieberman, so this paperwork kind of slowed down because there was concern, about whether FEMA would reimburse or where the payments would go if the process wasn't followed. And so sometimes, just on faith, you at VA just had to make a decision to move forward if you were just going to have to bet that it was going to work out in the end. So there was some element of risk. But there's also this element of the state having to be involved, and you're not being able to really work with the locals where the need was very clear, and that you needed to be nimble. So I hope that that we can work together to figure out what reforms do need to be made so that we can avoid these delays or uncertainties in the future.
Yeah, absolutely. I'd be happy to do that. And one of the things that we learned early, and that was the easiest to do, and that we always offered early on, is also if we could open up our beds as a part of this in VA facilities, where we usually had capacity and admit people while we were working on helping in other ways. So that was always an option that was on the table that ESF 8 was quite familiar with. But be happy to work with you, all of you, on this.
Thank you, Dr. Lieberman, and I share in your recognition of all the valiant work that your colleagues and all the VA employees did. They truly stepped up. Ranking Member Bost.
Thank you, Mr. Chairman. Dr. Lieberman, how involved are you in discussions with National Response Network federal partners now?
I would say a silver lining of one of the silver linings of the pandemic is that we have a much better relationship now than ever, and we are very involved. VA is now considered, whatever the topic is. We keep seeing that VA gets set. Who's going to be the member from VA, and we are now even being asked to co-chair committees. We're co-chairing two HHS committees on long COVID. We are involved with White House committees. We are asked to give advice to the CDC. So I feel like we are in a much, much better place than we were just a few years ago.
So you would say that the actions are being taken to strengthen VA's presence and planning the future responses to a level that we're being very wise in that?
I think we can always do more and learn from our experiences and see how we can do better, and that is what we are doing. We just had a meeting with CDC leadership, Dr. El-Nahal and myself, a couple weeks ago, to just talk about how can we further help each other and strengthen our relationship. So we're continuing to look at how do we improve these things.
Wonderful. Ms. So, how can the VA better partner with your agency during public health emergencies, or, as we haven't really heard about, during natural disasters even?
Again, my experience out in Navajo area, having a really good relationship with the Albuquerque area was very helpful. We knew each other. We were able to just pick up the phone and ask for and make those direct contacts ourselves out in Navajo. I don't think that was consistent throughout Indian country or other parts of Indian Health Service. So that's something that we want to work on now, is really working on that relationship building and really understanding what each other's responsibilities are, because there are some unique aspects of the Indian Health Service, and that's what we were able to do as well when we had these teams from the VA come to IHS. There was an opportunity to teach them to understand, some of the challenges that we deal with in Indian country, the water infrastructure issues, the distances that people have to travel, the remotenesses of our facilities and locations. So I think that's what I had heard from even the teams on the ground. We're very, very thankful for the opportunity to be in our space, if you will, and I think as we move forward, there's an opportunity to really train across both sides, so we better understand what the VA is doing as well, and the needs that they're providing to our veterans. Thank you.
So do you believe that there is a good open line of communications now that you did not have before?
I would speak again from my experience. I worked in the Portland area as well and worked very closely with the VA in Portland over the years, even as an Indian Health Service employee. It really had a good collaboration. It just so happened that the individual that was in Portland is now the visiting director that was over the Navajo region. So that was very, very helpful. But I think it is, for all of us, I think, I've already in my position in 2.5 months, I have met with the VA Tribal Advisory Team. I've been having many conversations with the VA staff on the Indian Health Service and the Tribal Veterans Program side for the VA. And that's been very helpful, just opening those doors and having those communications. I think we are in a much better place today than, and in spite of the COVID and everything else, we are in a good place now to continue that relationship. Thank you.
I just want to say thank you to all of you. We know it's been a rough 3 years plus, and for stepping forward. And with that, Mr. Chairman, I yield back.
Thank you, Ranking Member Bost. Chairwoman Brownlee.
Thank you, Mr. Chairman. And I, too, want to thank everyone for all the work that they have done, because it has been a tough 3 years. And we just appreciate it very, very much. I wanted to ask, you were talking about, interagency coordination now is better and, a silver lining from the pandemic. But what about coordination around some kind of other disaster? And I kind of feel as though we certainly have to prepare for another pandemic-like situation. But I think with the climate the way it is, the likelihood of a natural disaster is probably more likely, that will be the next disaster that the VA will have to face up. So I'm wondering, we're talking a lot about the pandemic, but I'm also worried about how we're kind of preparing for other types of disasters.
So definitely, as you had been asking in the prior panel, tabletop exercises are one thing that are very important. We rehearse in the Veterans Health Administration. We did before the pandemic and have continued to look for that. The federal space has done some tabletops. I actually did participate in one prior to the pandemic with federal interagencies. There are some going on right now, but I agree that we need to keep preparing for different possibilities of what might go wrong. Tammy, do you have anything you want to add?
Chairman Brownlee, in May, I actually participated in a live exercise in Puerto Rico. Where we did bring in all the federal partners as well as the state and did a coordinated response for hurricane. And we also did it in a COVID environment. So we exercised it as if the patients that we did not know whether or not the patients were coming from a COVID area. So I do believe that for natural disasters, we have continued those exercises. We are using our equipment, we are staging assets, we are having our federal partners walk through our assets. We've brought them into Martinsburg so they could see what we can offer in the event of a natural disaster. So we've done quite a bit to prepare for a natural disaster, even if in a COVID environment.
And we certainly have also had real-life experiences. We had some very serious hurricanes that the first summer of the pandemic, which we supported with missions and were very involved through the ESF aid. Again, same group of individuals were triaging both for the hurricane as well as for the pandemic at the same time.
Thank you for that. And so, Dr. Lieberman, I wanted to talk a little bit about actually the chairman's first question in the hearing about the VA took, steps to scale up their hiring authorities so that you could do it more quickly. And I think the VA had, success in making these sort of fast hires. it seems to me that our hiring within the VA is, without a pandemic, without a natural disaster, it's still sort of in emergency status as far as I'm concerned, because it still takes so long to bring to onboard someone. So could you, are there lessons learned here? Are there things that we can do on a normal protocol to that we learned from the pandemic that we could be doing now to hasten our hiring process?
So first, I just want to acknowledge how one of the many benefits of the VA healthcare system is how agile we can be. That even early in the pandemic, when there's one part of the country that wasn't that hot with COVID, we could look for volunteers to move to another part of the country, and we did that early in the pandemic to New York City, and then followed with that as other hotspots developed in New Orleans and many other places around the country. So that's something that's really a benefit of our unified healthcare system. Certainly we learned a lot early on about hiring fast, and this is a priority for Dr. Elnahal, our Undersecretary. It's his top priority, in fact, and so we really have been focused on this and how to cut down on steps with hiring that are not necessary, and that's why about a month ago, we had our onboard surging events where we interviewed people on the spot, then got them their physical examination, their fingerprinting, all their testing and other things, and offered them jobs. And we were able to successfully offer jobs. It was over about a month's period, about 12,000 new staff with these events that we were having around the country. And we really learned a lot from that also. And so that really was built upon the work that had been done previously on how do you really hire rapidly. And we see that as a benefit in moving forward of trying to do as many steps as we can on one day. And agree with you, Chairman Brownlee, that this is something important that we have to keep focusing on. And last year was our best hiring year ever. This year we are on track. We're doing much better. And this is just a priority for us, and we have to get this right.
Thank you. Thank you for that. I yield back, Mr. Chairman.
Thank you, Chairwoman Brownlee. Mr. Mervan.
Again, I would like to reiterate, thank you for the last 3 years in providing world-class health care and emergency readiness for our veterans and being prepared. Director So, VA and IHS are perhaps the most similar federal health partners. Both have a nearly nationwide physical footprint. Both provide care to its enrollees for decades. Both treat a predominantly rural, low-income, and high-needs population. Perhaps most similarly of all, both have a workforce that approaches their mission with a professional and moral urgency that is unseen in any other healthcare system. The IHS has not had the attention or resource-rich support from Congress that VA's had, and yet the service navigated these 3 years with the same unrelenting drive and creativity we saw in VA facilities. I want to commend you and your workforce for your incredible service. I want to ask you about the working relationship between the VA and the IHS during the pandemic. VA had IHS entered into 11 interagency agreements with either or other, as well as the Navajo Nation and the Hopi tribe. Through these agreements, your agency was able to move critically ill patients to VA, accept VA staff in the facilities with workforce shortages, and share PPE. My understanding is these interagency agreements for this kind of humanitarian care are new and were created during the pandemic. Tell us how the agencies came to establish these agreements and what sort of permanent authorities, if any, you both need to respond to humanitarian crises more quickly.
Thank you. Thank you for that question. There are many things that I know that, again, I was in the Navajo area when the at the height of the pandemic in Navajo, and also where COVID hit first in Indian country was the Navajo area. So I think that, as I've said before, there's already now a foundation between the Indian Health Service and the Veterans Administration. I think working more closely together and allowing us to continue to at times share resources. We're even talking, again, the Secretary of the VA was out in the Gallup area on some other issues, and we're talking about it now, how about sharing facilities. And there are examples in the Navajo area where the VA staff are working inside the IHS facility already. So we need to build on those relationships to, again, better enhance where our Native American and Alaska Native veterans don't have to travel far distances, that they can be seen in the IHS facility closer to their home and also utilize the reimbursements that are being had. I will also say that I think bringing parity to not just the funding, you know, the VA has advanced funding, IHS does not. So that's critical in making sure that there's some parity and equitability there because of the work that we both do. And then the other part is Title 38. Title 38 is fully available for provider salaries to the VA, and we're still trying to work on some parts of that for the Indian Health Service. So that, again, creates inequities because our staff sometimes just rotate, at least from Indian country, they rotate to the VA and then come back to Indian Health Service. So stabilizing that by having some equity and parity would really standardize the healthcare system for both entities. Thank you.
Dr. Lieberman, I understand you sat in almost daily meetings at the HHS representing VA. These meetings were emergency support function number 8 meetings. ESF 8 is public health and medical services, the literal backstop to the civilian healthcare system. Given your experience, can you give us an overview of the ESF number 8 and the VHA's role in supporting it? I know you've talked about it, but expanding.
I'd be happy to, and then Ms. Zarnecki may want to add also with her role. So we are there to help discuss the requests from the states, to discuss whether what kind of support we think is needed, and there is an opinion given by the members of that, so that's something that's reviewed, and then it's discussed who best should take on some of those missions. The VA was the go-to organization, particularly for the long-term care facility issues going on around the country, the nursing homes and the state veterans homes. And so whenever requests came in, we were always the go-to for that. But there was always discussion there on what the needs were for the country, what were the priorities, and how we could best meet them. Zarnecki, anything to add?
No, I think you covered it. Additionally, we did add a employee into HHS so that we could work on that coordination, and that employee continues to work with HHS.
And just a very quick follow-up. Can you explain how these mission assignments are assigned? What is the process FEMA goes through, and how does VA decide if it has the bandwidth to assist?
I can help with that question. When the mission assignment comes in to FEMA, it comes through the state, goes into FEMA. FEMA then brings it to that council. There is a discussion about who would be best to meet that mission. And as Dr. Lieberman mentioned, a lot of times for community living centers or nursing homes, VA was seen as having that expertise. So whoever can meet that mission, then there is an ask of the agency to see if they can meet the mission. We bring it back internally. We determine whether or not we can meet the mission. We let FEMA know that we will take the assignment, and then we start to staff it. FEMA works on the paperwork. It goes through our general counsels, and is.
With that, I yield back.
Thank you, Ranking Member. Thank you, Chairman Ravan. Doctor, I'm going to go for one more round, and I may be the only one to ask questions, but Dr. Lieberman, in last year's NDAA, there was an amendment that allowed the Assistant Secretary of Defense for Health Affairs to carry out a pilot with VA in 5 locations across the country to improve the interoperability and capacity of the National Disaster Medical System. The pilot is set to begin before the end of this fiscal year. Has DOD reached out yet to bring consultations on this pilot?
I'm not familiar with that. Certainly, we can check about that.
Okay. So your staff, there's been no outreach by DOD. Now, given the conversations we've had with VA over the last 2 years regarding disappointment in DOD and their perceived absence from the civilian response or lack of coordination with the VHA, do you think that a pilot of this nature might be better led by VHA?
DOD was involved during the pandemic with the ESF-8, was involved with accepting missions. So just from my perspective, we were all busy battling the pandemic, and so different organizations would take different opportunities to cover the missions. Certainly we can take a look at this and discuss the best way forward.
Yeah, I understand the caution, and I don't want to ask you to step on toes necessarily, but I think it'd be helpful to Congress to understand just how agencies behave, departments behave, because if we do need to look at who should lead, who's better, who's better by their nature better able to lead as far as the agency. I think we need to get some frank discussion about this. In the wake of disasters, one of the critical fourth mission roles the VA experts can play is supporting community mental health by sending mobile units and joining teams at disaster assistance centers like after the Pulse nightclub shooting or January 6th attack. Can you tell me what goes into the decision making and who ultimately makes the call on deploying mobile vet centers?
Whenever there is a tragedy like you described, we err on helping out, and so we typically, on the day that it's happened, the leadership over the Readjustment Counseling Service, Michael Fisher, and the Undersecretary or myself have a conversation to discuss how we support it, but we believe that we need to be there. We believe that this typically will impact on veterans, and whenever we go to these locations, we provide help for veterans who sometimes find these episodes triggering for their own experiences, and so we try to help as much as we can in these situations.
Thank you for that. Director, so, one of the real standout successes of the interagency work during this time was during the time of the pandemic was the interaction between VHA and IHS. And VA leadership, from what we understand, found those interactions successful. From your point of view, what was your experience or the experience of your staff?
Thank you for that question. Without a doubt, we were grateful for the work that we have and the relationship that we have with the VA. Again, I lean on my role in Navajo area where it was seamless to be able to move patients from point A to point B, and also the paperwork and everything that needed to go with that for our non-veteran patients. I would again, and I just have to give a shout out to the VA and also the Indian Health Service staff for finding ways to make this work together. In the early stages, crafting those agreements was much easier than sort of the second go around. But when it worked well, it worked really well. There were a little bit of some confusion the second go around, meaning when those agreements expired, we had to up them again, and those took a little bit longer. But nonetheless, we know the value of those agreements and how we were able to use them to meet the needs for our patients.
Yes. So, is there anything else more you would say that VA needs to do differently in these joint efforts that are specific to emergency responses?
I think collectively, as a federal agency, federal government, that, just bringing down these barriers and working together more like we are doing now, I see that more now than I have ever in my career as a federal employee. So bringing those barriers down and really understanding what each entity can bring to the table, I think is going to help us moving forward.
Well, thank you. Thank you for that. And with that, Ranking Member Boss, would you like to, any questions? Ready to close? Chairman Van, is there any questions you would like to ask any further? Frank? Okay. So Ranking Member, if you would like to make a closing statement.
Yeah, thank you, Mr. Chairman. I would just want to thank you once again for the witnesses who are being here and sharing their experiences with the committee. And I look forward to working with everyone here to ensure VA is ready with the resources and involved when any of the nation's citizens, especially our veterans, are faced with national crisis. And with that, I yield back.
Well, thank you, Ranking Member Bost. This completes the questioning for the panel. I should have said it before. I thank you, Ranking Member Bost. I thank you all for joining us today. We've had a very productive conversation. I do hope that I can work with the Ranking Member, who will be the chairman in the next, at least I think you'll be the next chairman, in the next cycle, in the next Congress, and that we can take some of the lessons that we've learned today and try to institutionalize them, institutionalize these changes. And I appreciate your willingness to engage with us on these complicated topics. This is certainly just the beginning. From what we covered today, it is clear there is really a lot to be done. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. And again, thank you for appearing before us today, and this hearing is now adjourned.